to join us for this webinar. Hopefully you'll find it useful, kind of coming from people that want to help you with fecal incontinence. So I'm going to go through kind of our presentation, and then as Jessica mentioned, any questions, please ask them. So this is my picture when my hair looks good versus this is the real life version after working all day. So this is kind of highlights that a lot of people struggle with fecal incontinence. We know that a lot of people don't like to always come forth with it, even with their gastroenterologist. And kind of sometimes it's accidental how we come upon where they are willing to, say, yes, I do suffer from this, because often, it's a source of embarrassment, limits their functionality so much. So common questions, kind of, will I ever regain control? How can I possibly go on a date, attend an outdoor celebration, especially if there's food, get a job, often, afraid to leave your home, and then always saying, well, where's the bathroom? I need to know where the bathrooms are anytime I leave my home. So that's just stating 54% of people with fecal incontinence, which is stool leakage, have discussed it with their doctor. So a lot don't. And so we're hoping, continue to hope that that changes with speaking about different ways of treating it. So you're not alone. Women and men, both of all ages, suffer with this. So this is not just as we age. It can cause, serious issues, lower quality of life, kind of being able to do your day-to-day routine. Quoted that 1 in 12 have fecal incontinence, and so if you say, well, that's quite common if you think about the U.S. population. So what is expected, what isn't? This is what I was speaking about earlier. It's not an inevitable part of aging. So we have young mothers that have delivered babies and have difficulty. So it's not just, oh, my grandmother who's, in her 80s has difficulty. So kind of, always looking for it in all ages. So, when you think about kind of, if you're suffering from this, do the following sound familiar? So once again, planning activities around the bathroom, involuntary loss of stool, where you don't get the sensation and then you find stool, in your underwear or on the bed after sleeping all night. Stool present every time you urinate. So you sit down to urinate, your pelvis relaxes and there's stool there. Stained underwear, using pads or protective garments. And that's very common, where people use pads but don't really want to say, that they're wearing a pad to, accommodate for their stool leakage. If any of these apply, that's your body trying to tell you something that it has being difficulty doing the normal functions it used to be able to do. So how does bowel control work? We deal with this a lot in motility, where the intestine talks a lot to the brain, and that's essential. So sometimes it can be, there's a breakdown between that communication. And that's kind of the theory behind trying to use Interstim to help the nervous system to be able to talk and improve the intestinal function, specifically the rectum. As most of you probably know, if you have GI issues, the digestive system pushes food throughout our intestines. When your rectum is full, and the rectum is the bottom part of our large intestine, when it's full, it stimulates nerves that tell us, oh, it's time to go to the bathroom. But sometimes those signals fail and the stool has a mind of its own. The good news, treatments can get you back to living your life and being an active member without having to be tied to the bathroom. The conservative treatments we deal with a lot as gastroenterologists, trying to manipulate what your stool looks like, what it consists of. And then the advanced therapies, of which there's several, but this specifically focusing on Interstim, to try to stimulate those nerves and get that control back. Once again, this is kind of what I just stated. Simple solutions can help some people, but sometimes it's not enough, and it just keeps being tried. So we try to say, well, if we've done that, we need to move on. Even if you're on medication therapy, but we're not getting full relief, then this is something to consider. And that's just kind of listing what some of you may have been through with manipulating your diet. I'm just eating the wrong thing. Physical therapy, biofeedback, trying to retrain the pelvic muscles, and then medications that we use to try to form the stool, try to slow down the intestine, improve the consistency, but nothing really being able to, per se, restructure those rectal muscles. And then if conservative treatments don't deliver the results you expect, more options. So there's minimally invasive treatments, and then surgical options. So our colorectal surgery colleagues often do that, but not terribly effective in the long run. So that's a challenge with surgical intervention. And it's important to understand the trade-offs before you decide which avenue you're going to pursue. So surgical options that aim to physically repair the anal sphincter muscles or open the large intestine out through the abdominal wall, include anal repair, sphincteroplasty, which is a fancy term for trying to improve the function of the muscle that helps us empty our rectum, and then colostomy, which is what it's referring to as the large intestine coming out through the abdominal wall. Minimally invasive treatments would be Interstim, that this gentle nerve stimulation that's delivered via the Interstim device targets the communication pathway between the brain and the bowel and restores bowel function. It's clinically proven to stop or greatly reduce bowel accidents. It improves quality of life. It's a testable therapy that is safe, minimally invasive, and has been around for quite some time, since 2011. There's the recharge-free and rechargeable device options that we make when it comes time for the permanent placement. For most patients, it takes one simple evaluation in less than 1 week to determine. So basically, you come to our center, and I'm at Coon Rapids, MNGI Coon Rapids location. And you come just as if you were having a scope procedure. It's an outpatient procedure. We basically have you lay on your abdomen with your pelvis kind of tilted a bit up, and then numb the skin of your back and put 2 little small wires through to target your nerves, and then hook it up to the Interstim trial device to say, okay, does stimulating these nerves help you? And that trial goes on for a week, and then you come back and we remove the wires and give you feedback about how you responded. And usually too, I should say, because you're the one experiencing the trial. But we'll go over, once the trial is complete, you'll go over it with me. So the say yes to the test, that's, there's nothing to lose by trying if this is really, impacting your functioning, because if you don't respond, then, we tried, and, but you never know unless you try it. So we get asked a lot about kind of MRI, ability to have MRI if you respond to the temporary placement and want to have a permanent placement, but that is possible now. So that's not something to limit. And then, is this therapy right for you? You may be a good candidate for Interstim if you have significant chronic, stool leakage symptoms. You've tried conservative measures, including diet changes, medications, and these treatments haven't given you the complete relief you want. So this is going kind of through the proven results of the long-term efficacy. So 89% of people using Interstim experience long-term success that then improves their quality of life and get rid of those kind of restraints on their day-to-day functioning. And as I stated earlier, has been around for a long time, so safe and effective. I would say, just to mention, the most common side effects, adverse events during the clinical studies, included pain at the implant sites, new pain, migration of the leads, infection, technical or device problems, adverse change in your bowel or voiding function, and undesirable stimulation or sensations that may require additional surgery or cause return of symptoms. So there's always risk to every intervention, even with medications or things that are conservative, where you don't respond, or you have side effects that are not tolerable, or over stimulating the bowel when we're trying to actually help the rectum empty better, so the stool doesn't leak out of the rectum. So very typical of everything we do in medicine. They're trying to balance the risk and the benefits. And this is a patient saying, Interstim has given her the freedom to stop searching for restrooms or worrying about, having leakage when she's, doing her daily routine. I actually have a patient too who, one of my first patients actually that I followed for a number of years, who is a marathon runner, and it was impacting her ability. She was in her 30s at the time, impacting her ability to do marathons because she would run and then have accidents. So this allowed her to be able to participate in something she enjoyed, and having that control to be able to train and compete in those events. Okay, I think that sums it up. This is just, feel free to ask questions, and that is my name and our main number for MNGI to access if you want to discuss it more. I should say there are 5 of us in the motility clinic, so we try to get you to the people that kind of manage this long term.
Dr. Grudell, we have a question if this isn't covered by insurance.
So that depends. It usually is. So is there a specific, have you looked into it, like a certain program?
I'm not sure, that it was just a generic question if it was covered.
Sure. So yeah, so like most devices, we get a prior authorization before the placement. Just like if you come for a colonoscopy, we try to get that coverage, so that going into the trial.
Perfect. And then what will the stimulation feel like during the test?
So it's usually kind of like a mild vibration, kind of like a fluttering sensation as your nerves are being stimulated. That would be my best description.
Perfect. And just a reminder for people, if you have any questions, you can use the Q&A function at the bottom of the screen. And then we can have those asked to Dr. Grudell. Do you need to be careful going through metal detectors or through security at the airport with an implant?
No. Yeah. So that's not something you have to let them know. Yep.
Perfect. Here's another one. This one says, what if you already have a bladder stimulator, and do hemorrhoids affect any of the methods of treatment?
Hemorrhoids can definitely, so with a bladder stimulator, that's this.
I was going to mention, like, if it's a Metronic Interstim, this does work for both bladder and bowel. So, I would say if you are experiencing stool leakage or anything when it comes to bowel, we could work together. I don't know who did the bladder stimulator, but you could work with your physician to see how it works for both. But then Dr. Grudell, if you want to speak to do the hemorrhoids affect any of the methods of treatment?
Yeah, so, hemorrhoids can definitely I think this is what this is getting at. Hemorrhoids can definitely affect like your rectal emptying ability. So sometimes, if they're internal hemorrhoids, that's usually where we see most of the problem, where they're bulky. And so sometimes you say, well, I sat down to the toilet, I had a bowel movement, but I don't feel like I emptied well. So then that stool is kind of retained. So that's something, that is a kind of issue that's impacting the ability of the rectum, but it wouldn't preclude you from having an interstim because that's working on the nerves, kind of try to help different than the hemorrhoids.
Mhm. And then we had a question if there is an age limit. They're almost 77 years old.
No.
Yes, correct. I was going to say there is no age limit. I definitely think, coming in for the test would be good. Another question was, can Interstim be a first option or should other options be tried first?
No, I think it can be a first option, because oftentimes, sometimes depending on, how severe it is, how long it's been going on, where we say, okay, like you said, we have nothing to lose, we're going to trial this. We can always say, well, if it doesn't work, then we're combining it because we often sometimes combine, medications or fiber to bulk the stool with other, options. So yeah, I don't think, no, that you would have to progress. That's not required. No.
Great. What else? I think people were starting to get more questions as they saw or heard from other people. Dr. Grudell, can you talk about what the test is like in your office or where that's done?
So it's done in our endoscopy suite. So, if you've come for a colonoscopy, usually, well, at Coon Rapids, second floor is our clinic, and then the third floor is where we do the procedures. So you come to kind of that same place, the same admission area, where we have you change. And then, so you'll see our nurses, and then we walk you back to the procedure room and kind of walk you through. So it's not like, you're going to get propofol like you're having a colonoscopy. So you're able to talk to us. It's just local anesthesia to help with placement of the wires.
That's perfect. I know that we have, let me see. If leakage is very sporadic, is this still a good option?
Yes. Yeah. And kind of, I think because too, we struggle a lot with this where it's intermittent, but it's very unpredictable sometimes. So people can say, I was good for 2 months. And then all of a sudden, I was walking my dog and, had this happen. So yes, I think it is good to consider that.
How does one get identified if they qualify for this, like with bowel leakage? Like, how does that work?
It's basically based on your symptoms where you say, I'm not aware of stool or stool is coming out when I didn't expect it to be there. Um, and usually the standard of care is we would usually consider doing a colonoscopy to make sure that the rectum looks okay and that it's not inflamed or there's a polyp that's affecting its ability to hold on to stool and things. So we usually that would be something to consider. But then once we say, yep, the rectum looks okay, we're worried about the rectal function, then that's sometimes we do further testing of the rectum where we do manometry, which is a test to kind of test the rectum, like how it senses things, how it feels pressure. And then that helps us say, yep, we need some extra, it looks like it needs help beyond special physical therapy for the rectum. So that's usually how we identify people, say, yes, this would be appropriate based on your evaluation.
Great. And then we have another question saying that they have accidental leakage of passing gas. Is that something that you see normally be treated with this?
Well, it's really targeting, it can help that because it's an example of, but it's really targeting the fecal incontinence. So that's what we look for in the trial to say, okay, would you, if the stool leakage, would this be successful for you if you have a reduction? So it's not specifically looking at gas, but sometimes that goes along with it. Yes, like your rectum's ability to hold, distend, kind of accommodate, um, gases, but really it's what we're looking for in the trial is the stool.
This patient is asking, I have to avoid certain foods throughout the day if I want to attend an activity. Would I still need to modify my diet if I were to get Interstim?
Not necessarily, yes, because often it's like the diet can be a component, but it's not really fixing the underlying problem. So we still have that issue of, okay, the rectum isn't performing like we'd like it to, and having support of it. So often there can be liberalization of the dietary restrictions because you have that support.
Perfect. And we have another one. It said, um, so someone had one taken out. I think there's someone that we'll follow up with because they had a broken lead wire. So we'll make sure we talk to them. Do you have patients go through pelvic floor therapy first? Someone's asking because they've been through pelvic floor therapy and they feel like it's not working.
Yeah. So that's reasonable. That's part of the conservative approach to say, okay, we've tried, can we strengthen those muscles? But then, yeah, if it's not possible, it's not working, we're trying, right? But it's not, then, yeah, we say that's not successful. Yeah. Move on kind of thing.
All right. I don't think we have any more questions right now. Was there anything else that you wanted to address, Dr. Grudell?
No, no.
Perfect. Well, I will just say thank you for hosting this event with us tonight. I feel it was extremely informative and we're grateful for your time. I think, as you can tell from the questions, everyone's situation is unique. So it's also always very beneficial to make an appointment. Dr. Grudell, is accepting appointments. So make sure to schedule with her if you want to talk more about this and answer your questions. So perfect. Thank you so much, Dr. Grudell.
Yeah, thank you. Everyone have a good evening.
Good night.